My name is Dr. Christina Marcaccio. I'm a vascular surgeon. I recently started practice in this area. I'm currently seeing patients at Beth Israel Deaconess Medical Center in Boston, Beth Israel Deaconess in Milton, and then we'll soon be opening a clinic in Quincy as well. Unfortunately, that's not quite there yet, but soon. Thank you very much for the opportunity to come and chat with you today. I've decided to provide a contemporary overview on peripheral artery disease from my perspective as a vascular surgeon. And I have no disclosures. Today I'll provide an overview of peripheral artery disease, or PAD. I'll discuss the scope of disease in this country, the common risk factors associated with this disease process, the tests that we use to diagnose peripheral artery disease, and then talk quite a bit about the management, including both non-surgical and surgical options. And I'll end by highlighting some new and exciting minimally invasive techniques that we have available to us for helping treat peripheral artery disease. I'll be happy to take questions at the end, or if they come up during the middle, also happy to take them as well. So I'll begin by discussing the basics of peripheral artery disease. Arteries and veins work together to provide blood flow and oxygen to the entire body. The arteries carry blood from the heart to the arms, the legs, and vital organs in the body. And then the veins return blood from those locations back to the heart to be rejuvenated with oxygen and then to start the cycle again. Problems with both the arteries and the veins can lead to circulation issues or poor circulation. For the purposes of today's talk, I've decided to discuss problems with the arteries, that's peripheral artery disease, because this is a more critical problem. But at the end, I know there is a lot of interest in venous disease. I'm happy to answer questions and we can talk a bit about that as well, okay? The foundation of peripheral artery disease is a disease process called atherosclerosis. Atherosclerosis, then we have to begin by talking about that before we get into the details of peripheral artery disease. This process, I'm sure you've heard about what atherosclerosis is. It's the buildup of fats, cholesterols, and other substances in the walls of arteries. You can see this sort of plaque forming here. That's what it's called when these substances kind of come together to form an actual plaque or blockage in the artery. Over time, this plaque builds, and it can kind of decrease or completely block the flow through the associated artery that it's targeting. Sometimes, I'm sorry I don't have an actual pointer, sometimes these plaques can actually rupture and it can cause an acute clot to form, and similarly this can cause reduced blood flow through the area or a complete blockage of the artery at that location. The disease process of atherosclerosis can affect arteries anywhere in the body, and I'm sure you've heard of some of the associated disease processes that are even more common in the population. For example, when plaque forms in the arteries in the heart, this can lead to heart disease, and when complete blockages form, it can even lead to a heart attack. This is all the same disease process. Similarly, when plaques form and blockages form in arteries in the brain, it can lead to cerebrovascular disease, and when complete blockages form, that can lead to what's called an ischemic stroke, a complete blockage in the brain. When atherosclerosis or plaque affects the arteries that give blood flow to the arms, the legs, or the other organs in the body, this is what we mean by peripheral artery disease. Peripheral artery disease is much more common in the arteries affecting the legs and the circulation down to the feet than the arms, but in theory it can affect any of these vessels. Over time, the plaque can build up, as you can see here, and really restrict the blood flow through that segment and can again cause a clot to form, which completely blocks the flow, and this can lead to poor circulation. And when this affects the legs, in very severe cases, it can lead to limb loss or amputation. This is a very critical issue, and this is why I chose to speak about it today. For the remainder of my talk, I'll be focusing on peripheral artery disease, or PAD, affecting the arteries in the legs, but again, in theory, could affect the blood flow in the arms or other parts of the body. Depending on the severity of blockages in the arteries, peripheral artery disease can cause a variety of different signs or symptoms. Some people have mild blockages and have absolutely no symptoms at all. They may not even know they have peripheral artery disease. Usually, as the disease progresses and the blockages become more significant, the first symptom that patients will complain of is called claudication. This is pain that occurs in the legs with walking, and it's very reproducible. Patients will say, I can walk 100 yards and then I start to develop severe pain and I have to stop to rest. The pain goes away, then I can start walking again. The pain is typically described as a cramping type pain, almost like a Charlie horse, and most commonly affects the calf muscle, but it can affect the thigh muscles or even the buttock muscle, depending on exactly where the blockages are present in the arteries. But claudication is kind of typically the first sign of peripheral artery disease that patients will find. As disease progresses and the blockages become more severe, claudication symptoms that only happen with exercise can transition into rest pain, which is exactly what it sounds like. It's pain at rest. It's more commonly in the feet, actually, rather than the legs. People will complain of pain in the forefoot in particular. It tends to bother people while they're sleeping at night when the foot is elevated. And it's improved when they hang their foot over the bed, because when your foot's hanging down, gravity is sort of helping the blood flow to get down there. So many patients will say, Doc, I've got pain in my foot. It wakes me up in the middle of the night. I can't get back to sleep. It does help if I keep my legs down, or, so that's a very classic description of what is considered rest pain, and that's more severe than claudication. The most severe symptom of peripheral artery disease is tissue loss. This can involve sort of non-healing wounds on the foot, or gangrene, which is the medical word for essentially dead tissue that looks black. These patients in this category with tissue loss, so non-healing ulcers and gangrene, are at the highest risk for limb loss and amputation. So those patients require an urgent vascular surgery evaluation. I hope I've given you a reasonable overview now, at least, of what peripheral artery disease is. Now I want to talk a bit about the scope of disease in this country and some of the other medical issues that can increase your risk of developing peripheral artery disease. Atherosclerotic-related cardiovascular disease is the leading cause of death in every area of the world except for sub-Saharan Africa. This is a major issue, okay? Under the umbrella of atherosclerotic cardiovascular disease, which includes heart disease and stroke and other things, peripheral artery disease affects about 200 million people worldwide and about 10% of the population in this country. So again, it's a pretty common issue, varying degrees of severity. Peripheral artery disease more commonly affects men than women. So these orange boxes are men, the blue boxes are women, kind of with each age category. And the prevalence of disease does increase with age. So in patients in this country over the age of 80, about 25% of men and about 20% of women have some form of peripheral artery disease. And in that setting, it poses a pretty significant burden on the healthcare system in this country. As we talked about, many patients present with intermittent claudication. So that's that cramping in the calf most commonly that happens with exercise and gets better with rest. That's where most patients end up presenting to care with a vascular surgeon. A lot of different studies have tried to kind of understand the disease process from that point onward and how these patients do. So looking 5 years out after a diagnosis of peripheral artery disease, many patients with claudication just continue to have stable claudication, meaning their symptoms are essentially unchanged. They still have the issues with walking, but they don't get any worse. They don't get much better. That's the majority, 70–80% of patients. About 20 to 30% of patients develop worsening claudication over a 5-year period. And a very small subset of patients, 1 to 3%, under 5% of patients really progress to the point where their limb is threatened and they're at risk for limb loss or amputation. And that means progression to the symptoms of the rest pain that I described and development of non-healing wounds. I bring this up mainly to show you that most patients stay here. Very few progress to really severe forms of peripheral artery disease. But the other important thing to highlight here is that patients with intermittent claudication and peripheral artery disease, even in a more mild form, are at risk for other problems like heart attack, stroke, and even death related to cardiovascular causes. That happens in 20-ish% of the population, and that's probably because patients that have disease in the arteries in the legs also have disease in the arteries in the heart or the brain or other areas of the body. There are several known risk factors for peripheral artery disease. This figure is listing different risk factors on this left side here. And on the bottom, an odds ratio is basically telling you what are the odds of developing peripheral artery disease based on having one of these different risk factors. So the most significant risk factors for developing peripheral artery disease are smoking and diabetes. These patients have about a 4 times higher risk of developing peripheral artery disease than someone who doesn't smoke or someone that doesn't have diabetes. Other key risk factors include kidney disease up here, high hyperlipidemia, that's high cholesterol, high blood pressure, advanced age we talked about, and then male gender. Men, it's more common in men than in women. The distribution of disease and blockages in the leg arteries can vary depending on what risk factors a patient has. For instance, patients that have diabetes or kidney disease more commonly have disease in the arteries, this is the knee here, more commonly have disease in the arteries below the level of the knee. Meanwhile, patients that smoke more commonly have disease higher up in the arteries in the pelvis and in the thigh. You can imagine, though, that many people have multiple of these risk factors, and what that means is that they tend to develop disease in multiple different levels in the arteries, which makes surgical treatment a little bit more challenging. But this gives you a general sense of sort of where disease can develop based on different medical problems. Now we can talk a bit about how we diagnose peripheral artery disease and the different tests that we use, both in the office and in the hospital. The diagnosis of peripheral artery disease begins with a good physical exam and assessment of peripheral pulses, beginning at the groin all the way down to the level of the foot. So when I see patients in the office for the first time and I have any concern for peripheral artery disease, I check the femoral pulses at the groin level, the popliteal pulse, which is behind the knee, the posterior tibial artery pulse, which is kind of behind the ankle, and then the dorsalis pedis pulse, which is on top of the foot, okay? And weak or absent pulses at any of these levels can be a sign of peripheral artery disease. In normal people with normal circulation, you should be able to feel all of these pulses pretty easily. There are several different tests that we can use to help us diagnose and understand the extent of peripheral artery disease in a given person. The best screening study for peripheral artery disease is called an ankle brachial index, or an ABI test. It's here. In this test, we basically check the blood pressure in the arm, and then we check the blood pressure at the ankle, and we compare those numbers. So for people that have normal circulation, no blockages in the arteries in the leg, the blood pressure at the ankle is essentially the same as at the arm. When there are blockages in the arteries in the legs that impact the flow to the feet, the blood pressure at the ankle is actually lower than at the arm. So that's how we use that comparison to sort of understand the extent of blockages present in the leg arteries. Sometimes people will have a normal study at rest, and that's mainly true for the patients that have claudication because their symptoms are only present when they're exercising, right? When they're at rest, they have no problem. So they might have a normal ABI value at rest, but the way we test this is we actually make you exercise. We make you walk on a treadmill, and then we retest it. And patients that have kind of mild peripheral artery disease may have a normal study at rest, but a reduced ABI with exercise, and that helps us, again, to kind of better diagnose peripheral artery disease in those patients. It's kind of like a stress test for the legs, similar to how they do a stress test for your heart, same idea. There are several other types of imaging studies that we also use to help us diagnose peripheral artery disease and also kind of better evaluate where the blockages are and how we can potentially fix them. Arterial duplex or ultrasound study is an ultrasound study looking at flow through the arteries in the leg. This is an example down here. This is looking at the femoral arteries in the proximal thigh near the groin region. And this red is showing arterial flow through the arteries. It looks normal here. I don't see any plaque in this particular picture, but we use this type of study looking all down the leg to kind of assess flow through and blockages and extensive calcium, et cetera, in the arteries in the leg. CAT scans and MRIs are also used in helping us determine where the disease and blockages are in the arteries. This picture on the right-hand side here is a reconstruction from a CAT scan. When we do a CAT scan or an MRI, we give you contrast through the IV. That allows us to highlight the arteries really well so we can see the flow. And I don't expect you to be able to read a CAT scan, but these reconstructions are, this is the right leg and the left leg. Everything's flipped on CAT scans. And for instance, you can see here, there's a pretty decent blockage in that artery in the groin compared with that side where everything is nice and open. So we use these types of studies partly to help us diagnose peripheral artery disease, but also to help us figure out where the blockages are and how I can potentially fix them using a surgery or a procedure moving forward. And then the last thing here is angiography, which is an invasive procedure. I'll talk a bit more about that later, but that's another tool that we use to help us evaluate the extent of blockages in the arteries. I'd now like to transition to talking about how we manage peripheral artery disease. This includes actually a lot of non-surgical management strategies, which I'll talk about in detail, as well as eventually I am a surgeon. We do some surgery to help manage peripheral artery disease as well. The medical management of peripheral artery disease is multifaceted. I want to highlight this first point here, which is optimization of cardiovascular risk factors. What that basically means is that the first step in managing patients with peripheral artery disease is that we need to make sure that their other risk factors for peripheral artery disease are being well managed. So those are things like blood pressure control, good cholesterol medications, good control of your blood sugar if you have diabetes, et cetera. So all of those factors are really important for managing patients with peripheral artery disease. And you can imagine, I don't do all of that myself. I rely heavily on primary care doctors, cardiologists, endocrinologists, et cetera, to help. It's a team effort to really manage patients appropriately. From my standpoint as a surgeon, my first step in managing patients with peripheral artery disease is to make sure that they're on an antiplatelet medication. I usually start with a baby dose of aspirin, which is just this low 81 milligram dose that you can get over the counter. You don't need a prescription for it. That's my starting point with every patient with peripheral artery disease. Some patients need to be on Plavix or Brilinta for other indications, in which case I leave them on those medications. But if they're not on anything, aspirin is a perfect starting point. There's been a lot of confusion among my patients recently about whether they should be on aspirin, shouldn't be on aspirin, because I know there's been a lot in the news over the past few years about that. The FDA warnings that have been released about aspirin use don't really apply to patients with peripheral artery disease. The FDA announcement was basically saying that taking a low-dose aspirin daily may not be beneficial to preventing atherosclerosis if you don't have any atherosclerosis. So if you have no diagnosis of peripheral artery disease, heart disease, stroke, et cetera, there may not be a benefit to taking a baby aspirin just to prevent future problems. But for patients that do have heart disease, peripheral artery disease, stroke, aspirin is beneficial, or some form of antiplatelet medication is beneficial. So I would encourage you or anyone you know who's confused about this to definitely discuss this with your doctor. I've had a lot of patients just stop their aspirin, and I've been like, no, please restart your aspirin. So it's good to have the conversation before you change your medications. This has caused a lot of confusion for patients, and I understand it is a kind of a confusing topic, okay? Statin medications. I think everyone is pretty familiar with statin medications. These include Crestor, Lipitor, that category. These are medications that help lower cholesterol. They work extremely well. Several studies have looked at the impact of statin use in patients with peripheral artery disease and have shown that patients with peripheral artery disease who take statins have better survival and have better limb outcomes, meaning lower rates of limb loss or amputation. I always make sure my patients are on a statin. There's a lot of different statin medications, and some are better tolerated than others, so we can do trial and error to figure out which one's going to work for everybody. But being on a statin medication, if you have any form of atherosclerosis, is really important. There are a lot of newer cholesterol medications out there too, which I imagine probably have a similar benefit, but because they're newer medications, we just don't have clinical trials and studies yet to really prove that. But I would imagine that they'll be equally beneficial with respect to protecting your heart, protecting your overall cardiovascular health. Rivaroxaban, or Xarelto, is a different form of a blood thinner. It's been commonly used for several years now for the treatment of patients with atrial fibrillation, DVT, so blood clots in the leg veins, or PE, blood clots in the lungs. But more recently, it's been explored as a potential beneficial adjunct for patients with peripheral artery disease. There was a recent trial, it's called the Voyager PAD study, if you're interested, that basically looked at the use of a low dose of the rivaroxaban plus aspirin versus aspirin alone in patients with peripheral artery disease who underwent vascular intervention. And the results were very much in favor of the low-dose rivaroxaban having a benefit both from an overall cardiovascular health standpoint, but also with respect to leg-related outcomes, meaning lower risk of amputation and things like that. So the low dose of rivaroxaban is a really important adjunctive therapy for patients with peripheral artery disease. I don't put all of my patients on this medication. It's a case-by-case basis, but it's something I consider for almost everybody. Smoking cessation is the most important modifiable risk factor that you can treat in managing peripheral artery disease. Smoking not only increases your risk of developing peripheral artery disease, but it also increases the risk of having poor outcomes, meaning amputation and things like that, if you have peripheral artery disease. It basically accelerates the disease progression because it leads to faster deposition of plaques and things in the arteries. You develop more significant blockages if you smoke. I completely understand that smoking cessation, quitting smoking is not easy, and I really try to support my patients through this and work closely with primary care doctors and others to really help my patients in this effort, but this is the most important thing as far as reducing your risk of problems with respect to peripheral artery disease. The management of peripheral artery disease depends a bit on the severity of symptoms. So as we talked about, many patients with the milder form of peripheral artery disease just present with claudication. And because those patients are at relatively low risk for progression to limb loss or amputation, I have a much higher threshold to offer surgery. I'm much more conservative and really try to use different medical and exercise-based options, which I'll explain in a minute, to try to help their symptoms before we really jump forward to doing a surgical procedure. The mainstays of therapy in patients with claudication are all of the medical management strategies that I already mentioned, as well as exercise therapy. So what is exercise therapy? This is exercise at least 3 times a week for 30 minutes for at least 12 weeks. And exercise typically is walking. That's the easiest thing to do here. Ideally, this can be performed in the context of a structured exercise programs. We have one at Beth Israel in Boston. I'm sure there are other ones out there as well, but sometimes that's logistically challenging. So this can be done independently. And the majority of my patients, I actually empower them to really do this independently. When I explain how to carry out the exercise therapy, I tell everybody to walk through the pain, okay? It's almost like the same concept as an athlete really conditioning to get stronger, same idea, but you're conditioning your calf muscles or your leg muscles to really push through that pain that you develop because you have poor circulation there. I will say patients have really great success with exercise therapy if you really stick to it and do it properly. Multiple studies have shown that patients that really carry out this regimen, as I've described, have improved walking distance, meaning they can walk farther before they develop the pain. They have improved functional status, so they feel like their quality of life is less affected by the claudication symptoms. I've also honestly had many patients that have been able to completely avoid any surgical procedures by just doing this alone and then managing all of their medications appropriately, as I previously described. So exercise is really important, both for your overall health as well as for the management of peripheral artery disease. There is some data to support a potential role for a medication called cilostazol or Pleatol for patients that have claudication. It's a vasodilator medication. It basically plumps up the arteries everywhere, including in the legs. And the medication has been shown to help patients with claudication walk further before they develop pain. That being said, I've found that this medication has a lot of side effects. So while I offer it selectively, I have a pretty low threshold to take patients off of it when they have side effects. And it's nothing major, but it's, GI upset, things that are not pleasant. So I think that I really push for exercise therapy less so than this particular medication. But it does work really well for some people. Now we'll talk a little bit about surgery. So when thinking about surgical options for the management of peripheral artery disease, there are two general categories of interventions. The first is endovascular surgery, which is a minimally invasive surgery, where we open up blockages in the leg arteries with balloons or stents. Similar in concept to a cardiac cath, if that's something that's a little more familiar, where they go in and try to treat blockages in the heart with balloons and stents. It's the same idea, but for the leg arteries. To perform the procedure, we typically access the femoral artery in the groin with a needle poke, not an incision, so very minimally invasive, and then use wires and catheters to try to navigate across the area of blockage. Once we get across, we try to open it up by inflating a balloon to try to crush that plaque and open it up. And if the plaque recoils, meaning it doesn't stay nice and open after the balloon, that's when we go ahead and put a stent in to really get everything nice and open. This is a very well-tolerated procedure typically. It can be done as an outpatient procedure under minimal sedation, give a little numbing medication in the groin, a little sedation to make you sleepy, but patients are often mostly awake during the procedure. Just have to lie flat for a little while and tolerate it. And because it's a pretty low-intensity procedure, the recovery time is very short. And patients do very well with this procedure when it's an option. The second approach is open surgery to fix the blockages in the leg arteries. This can involve opening up an artery and essentially scooping out or cleaning out the plaque in the artery, or it can involve a bypass surgery where there's a long blockage in the artery and we use a graft to basically reroute the blood flow around the blockage, just kind of like dealing with a traffic jam. We just go a different route around it. This is a more major surgery. It requires general anesthesia, so patients go completely to sleep for this type of operation. And depending on sort of the extent of the surgery, often requires a 3 to 5 night stay in the hospital to recover and have physical therapy and make sure you're up and moving again before we let you leave the hospital. So the initial sort of insult or stress of this surgery is much higher than with the minimally invasive endovascular approach that I described previously. That being said, a good bypass or a good open surgical repair actually tends to have a more durable long-term result, meaning less need for us to go back in and touch things up with new balloons and stents and things like that. So it's still a very good option for most patients. When we think about different types of bypasses, meaning again the surgery where we actually reroute the blood flow around a blockage, there's different types of grafts that we can use to create that new path of blood flow. A patient's own leg vein is the ideal with conduit, meaning graft, to use, and we typically will use the saphenous vein, which runs along the kind of inside of the leg here. It's the same vein they harvest for CABGs, for heart bypasses. Same exact vein, so we fight the cardiac surgeons for that vein. But that's the ideal choice. It gives the best outcomes, best long-term durability for a bypass surgery. But not everybody has leg vein that is usable. And so alternative options are actually to take vein from the arm to use for a bypass, or we have prosthetic grafts as well that we can use, but the outcomes are not as good as with vein. So vein is always preferred if it is an option. As I already alluded to, for patients with claudication, my threshold to intervene surgically is much higher because patients can do really well with conservative measures of medical therapy and exercise therapy, and surgery can kind of start a pathway leading to more progressive disease. If I start intervening with balloons and stents and things like that, you're disrupting the native circulation, so you're introducing new risks of other problems in the future. That being said, some patients try everything. They try the exercise therapy and it's not enough and they're still miserable. And so for those patients, Surgery is a reasonable option, even with just claudication symptoms, but in that setting, I definitely tend to lean towards a minimally invasive approach rather than a more major surgery if they're a candidate for it. Usually with claudication, the extent of blockages is not as significant as with more advanced forms of disease, so it is possible to use a minimally invasive approach, and that is best. For patients with chronic limb-threatening ischemia, the discussion's a little bit different. So these are patients with more advanced peripheral artery disease that have the rest pain or tissue loss, non-healing wounds, gangrene, and things like that. For these patients, surgery is actually really necessary to prevent an amputation or limb loss in the future. For the patients that have chronic limb-threatening ischemia, both minimally invasive or open surgery is reasonable. It really depends on several factors. It depends on the patient's overall health and ability to tolerate a major surgery potentially, as well as where the blockages are and what I can do to kind of reconstruct the plumbing to get good circulation down to the foot. So not one approach is always best. Researchers in vascular surgery have been trying for years to try to assess open versus minimally invasive surgery and the outcomes long-term for patients in this more kind of critical category with rest pain or tissue loss. Two recent trials actually have stimulated a lot of buzz in the vascular surgery community. One is the BEST CLI trial, which was headed by actually a surgeon at the Brigham, as well as the Basel II clinical trial. And these are more updated trials. The previous data was from almost 20 years ago now. That gave us some insight into sort of the pros and cons of different approaches, meaning open surgery or minimally invasive surgery, but they still don't really settle the debate of which is better. And I think that's because which is better depends on the patient more than the data, essentially. But there's a lot more analyses yet to come and looking at different subgroups, subpopulations of patients, et cetera, to try to understand who might benefit from what and when. My personal bias is that I tend to favor open surgery in patients that have high anatomic complexity with multiple levels of disease, meaning multiple different blockages at different levels in the leg, because that's really hard to fix with wires and catheters and balloons and stents, and you can do a nice simple bypass to get around all the problems very quickly. So I tend to favor bypass in those patients. I also favor an open surgery or bypass in patients that have pretty extensive tissue loss that's going to take time to heal. Because like I said, bypasses tend to be more durable than balloons and stents. And so giving them a good durable revascularization with good blood flow down to the foot will kind of allow that process to take place over time. And then lastly, as I mentioned, if patients have good vein, I'm more inclined to do a bypass, but not always. Yeah, go ahead.
If you take a graft from the arm to put in the leg, what happens? Does the arm not need that? Is it?
Yeah, so when we take, from either the leg or the arm, when we harvest vein to use for a bypass, it's a superficial vein. Everywhere in the body, there's deep and superficial veins that work together to carry blood from the hand to the heart, the foot to the heart. And so the deep veins are actually doing the majority of the work. So the superficial veins are typically expendable. So whether we take it from the leg or from the arm, it's uncommon to have issues like swelling and things like that related to it. Yeah, great question. I think this last bullet is key, that no one approach is always best. So if somebody tells you, I only do open surgery, that's the wrong answer. If someone tells you, I only do balloons and stents, that's the wrong answer. You need to really weigh both options. All right, I'm going to end here by highlighting some new and I think very exciting minimally invasive techniques that are available to us for treating peripheral artery disease. And this is particularly relevant for the category of patients that I alluded to who have pretty extensive blockages but might have heart problems or lung problems or other issues that make them somewhat poor candidates for a major surgery. So this is a great opportunity to intervene on those patients. The first technique that I want to mention is called intravascular lithotripsy or shockwave technology. Okay, this takes a technology that has been used for years to treat kidney stones, lithotripsy. Kidney stones are calcified. Plaques in arteries can also be calcified. So they basically have hijacked that technology and applied it to arteries. This picture here is kind of a cartoon showing it at work, but we use a balloon and inflate it in the artery. You can see there's a calcified plaque along the side of the artery. And then this blue are shockwave lithotripsy pulses being delivered to the calcified wall of the artery. And what that does is it doesn't completely get rid of the calcium, but it breaks it. It breaks the calcium so that we can go in there and put a stent in and the artery actually opens up. Sometimes when we try to use just standard balloons and stents with plaques that are really, really calcified, the plaque won't budge because it's too firm. So this technology really helps us to kind of blast through and get the artery open in situations where it would otherwise fail with kind of the more conventional approaches. This picture on the right gives you just an example from a real patient. Here you can see all this white. This is an artery. The black is the blood flow coming through the artery. The white is all calcium. It's horrible. There's a lot of calcium in that artery. That's before. On the far right there, that's after shockwave balloon, okay? You can see there's still some calcium left because you can't get rid of everything, but there's really good now black blood flow going through that segment because they were able to blast through the calcium there. So I like to use this technology in patients that have pretty extensive blockages that have a lot of calcium inside the plaque itself. That's not everybody, but some patients have a lot of calcium, and this is really helpful.
Could that cause clotting? Could clots break off then?
Yeah, so not clotting specifically, but what you're alluding to is the idea of embolization. So when you blast that plaque, a little piece of calcium certainly can break off and go down to the foot or something like that. Is that what you're getting at? Yeah. That is a known sort of complication or something you need to at least be aware of when you're using this technology. We actually have little filters that I can put down into the artery below where I'm treating to catch plaque that breaks off and then pull it out at the end. But that's perfect point there. Definitely a risk. The next technology I want to mention are drug-eluting balloons and stents, okay? So I've talked about just standard balloons, which just opens up the artery, a standard stent, which is a scaffold that basically keeps the artery open. Drug-eluting balloons and stents are devices that are basically coated with a drug that penetrates into the wall of the artery and helps reduce the risk of disease recurrence in that location where you're treating. These devices have been used in the heart for a long time, okay? The cardiologists almost exclusively use these types of devices when they're treating arteries in the heart. They've more recently become available for treating arteries in the legs and have shown to have pretty good benefit with respect to less likelihood of needing to re-intervene on a segment because, again, that drug helps prevent recurrent disease in that location. I don't use these in everybody. That would be overkill, but for patients with really refractory or recurrent disease, this is a really good option. In general, when we think about minimally invasive techniques, we're still somewhat limited in what we have available to us to treat blockages in the artery below the level of the knee. Those are very small arteries, kind of more like the size of the arteries in the heart, actually. This tibial vessels, that's what I mean by that, is arteries below the level of the knee. And for patients with diabetes and kidney disease in particular, that's where their disease is. It's in those arteries below the knee. So we are constantly working to develop new techniques and technologies to really treat those arteries more specifically. And there are some new drug-eluting balloons and stents in trial currently that are designed specifically to treat the arteries below the level of the knee. And at Beth Israel in Boston, we're participating in these trials, so we have the ability to offer this technology to our patients as well when relevant. The next new and exciting technology I wanted to mention is a percutaneous bypass. PQ is the branded name, but percutaneous bypass, okay? This uses minimally invasive or endovascular techniques to basically achieve functionally a very similar outcome to an open bypass surgery. So you can see in this picture on the right, I'm sorry, my arm's not long enough here. The red is the artery, the blue is an adjacent vein, and this yellow is a really long blockage of plaque in the artery. So rather than doing an open surgery to make an incision above the plaque and below the plaque and sort of bypass the blood around it, this technique uses a stent to basically carry blood from the artery through the adjacent vein and then back into the artery, creating a percutaneous bypass, functionally very similar. There are very sort of specific anatomic criteria, limitations and things to qualify for this procedure, but it is a good option for a select group of patients who have appropriate anatomy and are really poor candidates for a major open surgery. We've done 2 of these successfully so far in Boston. It's a very new technique, but we'll be continuing to offer it to patients that qualify if we think it's reasonable. The last new technique I want to mention is called a deep venous arterialization, or a DVA. Bear with me, this one's the most confusing. It's sort of similar in concept to the percutaneous bypass that I just described. It's more specifically for patients that have really no conventional revascularization options and have disease below the level of the knee. This is the knee joint here. So we're talking disease very low in the leg. And what we do in this specific technique, again, it's percutaneous, so all pokes, no incisions. We reroute blood flow from an artery into the vein, but we don't enter back into the artery in these patients, like in that last procedure, because there's nowhere to enter. The blockage is complete. We basically create a fistula, same type of idea, fistula for dialysis, but we create a fistula in the leg. We're rerouting the blood from the artery into the vein, and eventually that vein becomes pressurized with arterial blood and can push more and more blood flow down to the foot, okay? So this is a very new technique. It was actually published in the New England Journal of Medicine a couple of years ago with pretty promising results. Again, this is something I only offer to patients with no other option, essentially, but it's a better option than an amputation. So this is a new technology that we've done several of these cases in Boston with good outcomes. I'd like to pause to highlight what I said. One, we can all miss this time, but to highlight that this is really a team sport, okay? Saving legs is not just about vascular surgeons. We obviously play a key role in a lot of the management of patients with peripheral artery disease, but it's a team effort with multiple different physicians, okay? And in that regard, we've created a limb preservation center at Beth Israel Deaconess in Boston. And the center is co-directed by vascular surgery, podiatry, so foot doctors, and plastic surgery, because sometimes we need to do some fancy reconstruction to really save a foot that has really extensive tissue loss. We also work very closely with the endocrinologists for the diabetes management in patients with diabetes, and the infectious disease doctors for patients that have bad infections in the foot. So it truly is a multidisciplinary effort. And several studies have shown that in patients with diabetes in particular, these limb preservation centers, multidisciplinary clinics really help improve outcomes long term. These patients that are cared for in these centers have lower hospital admissions, fewer amputations, better survival, and it also reduces the overall cost and care just to consolidate all of these efforts and get all of the right providers in the same location to really make things easier for patients. So I'd like to end by highlighting some key take-home points. Peripheral artery disease, it's caused by atherosclerosis in the leg arteries, as we discussed, and this can lead to limb loss or amputation if it's poorly managed. The symptoms of peripheral artery disease include claudication, which is the pain with walking in the calf, thigh, or buttock, rest pain, which is pain in the foot while not walking, or foot wounds that are non-healing. Medical management of peripheral artery disease includes antiplatelet therapy, so typically that's a baby aspirin, but can be other types of medications, as well as statin therapy to lower cholesterol, smoking cessation, and then management of other cardiovascular risk factors, which again includes good blood pressure management, diabetes management, etc. Surgical management of peripheral artery disease includes endovascular or minimally invasive techniques, or open surgery, and that depends on the patient and their anatomy and also what the patient wants sometimes. There are several new and I think very exciting minimally invasive technologies that are available for the treatment of peripheral artery disease, and we have access to these types of technologies and are using them selectively in patients that we think would benefit. And limb preservation is a team sport. It's not just about the vascular surgeon, it's about everybody. Lastly, I want to empower you to take ownership over your health and those around you to really help lower your risk of peripheral artery disease as well as cardiovascular disease in general. It all overlaps. Stop smoking if you're smoking, or tell whoever you love who's smoking to stop smoking if they're smoking. Go to the doctor, and that doesn't mean go to the doctor every week. It just means make sure you're up to date on your annual visits and things like that to make sure you're, and whether you have diabetes, you're seeing your endocrinologist, just make sure you really participate in your care and go to your doctor's visits, because management of all of the other things helps impact your risk of peripheral artery disease. Take your medications. Again, that's the antiplatelet medication if it's applicable, the cholesterol medication, etc. Make healthy diet choices. I generally talk to patients about a Mediterranean-esque diet. It doesn't have to be perfect, everything in moderation. It doesn't mean you can't ever have a cookie or anything like that, but really being mindful about what you're eating and how your body reacts to that is really critical. Keep walking or exercising in whichever way works best for you, but even walking alone is excellent for your health. And protect your feet, and that's particularly true for patients with diabetes. Protect your feet from any wounds, because any development of a non-healing wound can kind of precipitate a long pathway of needing to do a lot of work to save the foot. Thank you all very much for your attention today.